So guys, I'm here again, Scott Craig, EMT instructor here at Johnson County Community College. I've got Sean Biggs, I got Jason Parker with me to help through this particular scenario. We have one of our mannequins here to play our patient since it's an unresponsive patient. But we're going to talk about the differences between assessing this particular patient as opposed to the one you guys have already seen, the assessment of an alert and oriented medical patient. And so my big challenge here is that this patient is in fact unresponsive. They cannot answer my questions. They cannot necessarily tell me what is wrong. So anytime I have an unresponsive patient, I'm always going to assume that they have trauma until I can prove otherwise. And until I get to my patient and get my hands on them, I can't really prove that they don't have any. So we treat both of these different patient types exactly the same, and that's going to cause the order of our assessments to change slightly as well. So again, I want to make sure that I go through my scene size up. I want to make sure that my scene appears to be safe. I want to make sure I have the appropriate BSI. Again, if this patient had large amounts of blood or anything along those lines, I may need to use a little bit more than just the gloves. But after I have my BSI, I've been assured that my scene is safe. I now want to do the same thing that I did before. I want to make sure, as far as my number of patients goes, how many I have. Want to determine whether we're dealing with a medical situation or a trauma situation. Again, at this time, it appears to be unknown. Some of our scene clues may give us a little bit more of an indication as to why exactly this patient looks like this, but as of right now, I have no idea. And so, because, I know I only have one patient, but I'm unsure of the mechanism, I want to go ahead and make sure that I order the appropriate resources. I want to make sure that I get ALS on the way. I want to make sure that I have enough hands with me in order to deal with whatever we may find once we start to assess this patient. And so as I transition into my general impression, as I'm approaching this particular patient, what I want to do is to determine his age and sex. We'll call him approximately 30-year-old male. I don't hear any obvious audible breath sounds. I'm unsure whether or not this is a mechanism of injury or nature of illness at this point. I don't appear to see any life threats. I would want to make sure and see if he's breathing. And for intents and purposes of this, we will say that in fact this patient does appear to have some visible chest rise and fall. Want to make sure that the patient is responsive. His eyes are closed, so he does not appear to be looking at me or tracking me in any way, shape, or form. And his particular position is here on the ground. So again, it is suggestive of the potential for trauma, and I'm going to have to treat the patient like that. And I've wrapped up my general impression. Now I want to actually approach my patient. So the first thing I'm going to do, just place my hand on his head and just kind of give him a gentle tap. Sir, can you hear me? And he does not respond. So it's suggestive that he might be unresponsive. I'm going to have Jason come over here and just immobilize this patient's head. I want to quickly determine what his level of consciousness is. Now, he's not awake. He's not going to answer any of my questions. I may ask him, hey, can you hear me? Well, where are we? Anything along those lines. He doesn't respond to those, so I now need to move down through the AVPU scale. So the next thing I'm going to do is take my hands and place them into his hands and say, sir, if you can hear me, squeeze my fingers. He does not do that either, so I need to move through our assessments. I may pinch the backs of his hands, which is what you guys should do for your classmates. You may see some field providers go ahead and give him what we call a sternal rub here. Again, what I'm trying to do is to make any note of him recognizing the pain. He may grimace, he may moan, he may pull away, and in this case, the patient did none of those, so he is completely unresponsive. So I want to quickly have Jason open up his airway here. He's going to do a jaw thrust. We're going to look in there. We don't see any obstructions. I do still notice the patient visibly breathing, and so, I may just put my hands on his chest, make sure he has that bilateral chest rise still. Just want to make sure that my patient is breathing adequately. Want to make note of his rate and depth. It's common for your unresponsive patients to have shallow breathing, and so I may need to administer some oxygen to this patient or may even need to ventilate him. And so I want to make note of that. I want to make an educated decision. His breathing appears to be at an adequate rate and depth, so I'm going to have Sean here go ahead and get out a non-rebreather. We're going to place it onto our patient until we can continue through the rest of our assessment. I'm going to check his pulses real quick. The fact he is breathing suggests he is not in cardiac arrest. If at any time I suspected that, I'd want to make this a priority and would want to go ahead and start doing CPR if necessary. However, this patient does have a pulse as well. I'm checking the radial and the carotid. A little bit harder to see on this side close to me. But I want to check both of these and again, just make sure that they are present and they are equal. So what I've found so far is I have a patient that's completely unresponsive. That in and of itself makes this patient a high priority patient. So as I mentioned earlier, ALS is already en route. I want to triage again this patient red, at least until we can get a little better idea of what might be going on. And so Sean's getting out that oxygen. He's going to put that on there. And as I mentioned, this is going to kind of change how we do our assessment. The fact he's unresponsive makes finding his injuries of paramount importance. So as soon as Sean gets that on there, because of course oxygen is going to be important potentially in this situation, I'm going to go ahead and I'm going to start out with our physical exam. And so we're going to do a complete head-to-toe, front and back exam of this particular patient. And so the first thing for us to do is to start at his head. Now I've got Jason immobilizing his head, and I'm going to go ahead and just kind of start palpating. Okay, I'm going to palpate his scalp. What I'm looking for is what we call decap BTLS. And that stands for any deformities, contusions, abrasions, avulsions, punctures, penetrations, burns, tenderness, lacerations, swelling. It's a lot of words to make us, recognize that we're looking for soft tissue or musculoskeletal injury. So I want to make sure I check his scalp very good because his hair covers it, and sometimes you may find some hidden injuries in there. I'm going to start moving down to his forehead. I'm going to palpate it, make sure that there is no obvious fractures or any deformity there. I want to make sure that I go ahead and check his cheekbones, okay, or his zygomatics. I want to check the patient's nose here just to make sure. You may find some people place a hand on the head when they do this because sometimes it can be very sensitive. Sometimes the patient can jerk. Because he's unresponsive, that probably won't happen, but it's still good medicine to do so. I'm going to check his maxilla here, or his upper lip. I'm going to check his mandible or his jaw. And you guys will notice I'm starting here in the middle and working my way out, just looking for any deformity, any injury, anything like that. I want to go ahead and open this patient's eyes and take a look in there. I'm just looking real quick for obvious, signs of a blown pupil, potentially some blood in the anterior chamber, and I'll give a more thorough assessment of those a little bit later. Taking a quick look, seeing if there's any blood or cerebral spinal fluid coming out of the nose or the ears or any place out of the body, and again, does not appear to be. So as I move down or transition from the head down to the neck, I'm looking for all the same things that I did on Jason when he was our alert medical patient. The presence of jugular vein distension over here, the inline trachea, looking for that subcutaneous emphysema, kind of feeling for it. Some people say it feels like Rice Krispies or like that bubble wrap paper that you may have something shipped to you in. Don't appear to see that on this particular patient. I want to make sure that he does not have a stoma or a hole designed for his breathing. Want to make sure he's not wearing any medical alert tags. Sean, you check his ankles for medical alert tags for me. Okay.
I got one for sulfa.
Okay, fair enough. So we know that our patient has an allergy. So good to check all extremities everywhere for those particular conditions. And the other thing that I want to do is to palpate or to inspect his posterior spine as well. Just as I did with the nose, probably a good idea to place your hand on the patient's head because this can also be very, very tender and may cause him to move, which is we're trying to prevent. That's why Jason's here holding his head. So what I'm doing is just kind of taking my hands, and I'll come over here on this side to do it. But I'm palpating down from the back of his skull until I get to his shoulders, right down the spine, the cervical spine right there. Most commonly injured part, least protected part, and unfortunately it tends to be the most important. Trying to feel for step-offs, any deformity, any obvious sign of injury to that particular area. After I've done that, and this is again just simply my preference, I always like to start out with the top portion of the chest here. I want to check the patient's, check his clavicles. Again, you'll notice starting towards the middle and working out. Check his scapula, or his shoulder blades. And I also want to palpate the patient's sternum. Now the reason I'm doing this is because these are the structures that will support the cervical collar. Because of this patient's condition, I still need to make sure that I immobilize this patient properly. And once I've palpated that, I can go ahead and request a C-collar from my partner, and I can go ahead and apply it at this time. It's just good because it can help, remind the patient not to move their head, and it's an important aspect of potential trauma care, at least at this time. So I want to measure and apply this C-collar appropriately. I'm going to measure from the corner of the patient's, the angle of their jaw right here, the tip of their earlobe, and I also want to measure down to the top of their trapezius. And so once I do that, what I'm going to do is to measure that with, kind of my fingers here. It's not exactly the most accurate science known to man. But after I've got a general idea of that size, I want to transition it to our C-collar, and I want to see what 3 fingers looks like as far as this goes. I want to measure from the bottom of this plastic up, and wherever that 3rd finger happens to fall, that's where our C-collar is going to go. And we'll go into a little bit more detail on this when we cover full spinal immobilization in a subsequent video. Once we've got that, I'm going to go ahead and apply it to my patient. Again, you'll notice he's still receiving oxygen. Jason is still going to hold on to this despite the fact that we've applied it. And I'm going to continue with my assessment. I'm going to start with the chest, again, the same way that I did Jason. We're going to do what we call a 3x3. I caution you that some patients are larger than others. Some providers' hands are smaller than others. So all I'm doing is checking the entirety of the rib cage, looking for any deformity, any hole, any bruising, any obvious pain on my patient. Once I've done that, I again want to make sure that he's still taking adequate deep breaths bilaterally, and I also want to look for that paradoxical motion, that movement of a small segment in opposite of the rest of the chest wall. I don't appear to find that on this patient, so I also want to make sure that he doesn't have any obvious retractions suggestive of significantly labored breathing. I want to make sure he doesn't have any obvious accessory muscle use in his neck or chest, again, that would suggest that he is struggling to breathe. So once I've got all of that kind of chest area taken care of, I already palpated the sternum and the rest of it, I can transition down to the abdomen. And again, I may say, sir, can you hear me? I like to talk to patients that are unresponsive. Who knows if they can hear you or not? He may not respond, but I still do it throughout the entirety of my assessment. So, have any pain in your abdomen? Doesn't seem to answer, so we're going to assume that he doesn't. We're going to palpate all 4 quadrants, again, looking for guarding or bruising, rigidity, potential for evisceration, an open wound to the abdomen. We're going to look for that aortic aneurysm, suggestive of a very, very serious condition, or any distension, any obvious increase in the size of his stomach. After that, you'll find a lot of people like to go ahead and palpate the flanks. Really what I'm doing is kind of putting a little bit of pressure on the kidneys to see if this elicits any pain on our patient. I'm going to look for bruising and stuff like that when we do roll this particular patient over. So as I transition further down the body, I may want to go ahead and remove this patient's pants. We'll leave them on for his sake. But I'm going to go ahead and check this patient's pelvis. And when I do the pelvis, what I'm trying to determine is whether there's any instability of any kind, any tenderness, anything like that. While he may not be able to tell me tenderness, I may be able to feel when I put some downward pressure on the iliac crest or the bony protrusion at the front of the hips, or in at the greater trochanter, a fancy medical word for the hip sockets. What I'm trying to do is to determine whether or not he has any obvious damage to his pelvis. After I've checked both of those areas, in class you guys are going to do what's called symphysis pubis. And this is a small bone that is unfortunately in an area where we frequently do not palpate on our patients. However, if I do find that his pelvis is unstable, it would be appropriate for me to actually physically assess and potentially palpate the area around his genitals. Okay? So we didn't find anything on this, so we'll spare him that. And after that, I'm going to start moving down through my assessment of the legs. Now keep in mind, I've been talking throughout this whole thing, but this is a trauma patient, and one of our priorities is going to be time. And so as we assess this patient, we need to very, very quickly go through his legs. We want to make sure the femurs aren't damaged. If they are, they can hold a lot of blood, and the patient can go into shock very, very quickly. But a quick look at the femurs here, you'll notice I'm using what we call offsetting pressure because there's a very, very strong muscle around that bone. I need to put, pressure in different areas to try to actually physically feel if there's a deformity in that area. So I'm going to do the same thing over on this leg so you guys can see it a little bit better. I like to quickly cover the whole leg, even though that's not always part of this assessment. But once I've checked both legs, the next thing I want to do is to go ahead and determine this patient's neurovascular status. I'm going to go ahead, I'm going to check the pulses on the inside here. This is what we call the posterior tibialis on the inside of the leg, kind of where the ankle meets the leg bone. And then I want to check the dorsalis pedis. If you think about the foot like the back of a dolphin, like a dorsal fin, can help you to potentially locate it, almost smack dab in the middle of the top of the foot here. Just because my patient's unresponsive, I'm not going to assume that he can't hear me or follow my direction, so I'm going to specifically ask, can you wiggle your feet for me? He doesn't do anything. Can you feel me touching? Tell me which toe I have. Okay? Still an assessment worth trying, even if he does not answer. Now, we checked his AVPU earlier. He did not respond to pain. However, I may go ahead and try to elicit some pain down here to determine whether or not he has sensation. He can't tell me. That doesn't mean that he won't necessarily have it. So I may try to pinch the bottom of his feet right here. Some people may kind of run a pin or something underneath his foot. Again, just trying to determine if we get any response whatsoever to determine whether or not he has sensation in that extremity. I'm going to come up. I'm going to go ahead and quickly assess the arms. Again, kind of that offsetting pressure. I'm going to check his pulses on both sides. I'm going to ask him to wiggle his fingers. He can't do it. Ask him if he can feel me squeezing. He does not respond. And that is just going to be the case with some of our unresponsive patients. Now I've assessed his entire front from head to toe. I'm going to have Sean come over here and he's going to help me get this patient log rolled onto a long spine board. So I'm going to have Sean down here, and Sean, I want you to just place one hand on his hip here and one hand just kind of underneath the knee. I'm going to overlap or underlap with Sean. It doesn't necessarily matter, but it's important that we both kind of get some support here in the middle. I'm going to place this hand on the shoulder, and keep in mind, this is the only thing keeping the upper body up, so I never want to take this hand off during this log roll. We're going to log roll the patient always on the head man's count of 3.
Okay, 1, 2, 3.
And as we do that, well, there's some electronics. You should not find that on many patients. But I'm going to keep this hand on this shoulder again, palpate the back of the head or areas I couldn't palpate earlier. I can check the cervical spine again, get a good look at it now to look for bruising. Same thing on the back, run down the spine, look for soft tissue injury. Okay, the buttocks, it's medicine. You sometimes have to get familiar with these folks. And any part I can't reach, I may have Sean go ahead and just kind of palpate the backs of those legs. I may give him a little support here. But we just want to get a good assessment, good look at the back. We may never get another look after this because we're going to strap him to this board. So once we do that, I'm going to go ahead and reach for this board. We're going to roll our patient back onto it on the headman's count of 3.
1, 2, 3.
Okay. Now we want to position him appropriately. We're going to move him up. We're going to move him to Jason's right. Okay, all at the same time.
1, 2, 3.
All right, once we do that and we have our patient properly positioned on the board, we are going to put a cross across his chest, a box around his abdomen. We're going to put a figure 8 around his feet, and we're going to pad and tape his head. Now, we'll cover this in detail during spinal mobilization, but during class, you guys just need to verbalize this. After we do that, there is no reason for us to stay on scene. At this point, we would say cross, box, figure 8, pad and tape the head, and we would transport our patient immediately to the closest appropriate facility, in this case, likely a trauma center. Okay, so we're going to imagine that we have this patient fully immobilized to the board and we now have him in the ambulance. And so a couple of things that we need to do. First off, I did not check his breath sounds earlier, and I should have done that while I was assessing the patient's chest. Always good to do that during your primary assessment or at some point during your secondary assessment. However, once we get into the ambulance, we're going to have some time to do the rest of our assessments. As I mentioned earlier, our priority becomes the physical head-to-toe exam for this particular subset of patient, either obvious significant trauma or unresponsive. And so after that, we've got our patient in our ambulance, we've got him strapped down, I physically assessed his body. Want to make sure that I get some vital signs, so I'd get a full set of vital signs, pulse, respirations, breath sounds, would check, check his AVPU or his level of consciousness again, get a blood pressure. I would now thoroughly assess his eyes to determine if there was anything of significance there. I'd recheck his skin to make sure, whether or not he had some perfusion. After I've done that, after I've got my vital signs, now my real problem becomes in how to get the history questions from this particular patient. Because he is unresponsive, it's likely that he won't be able to answer any of them. So, I may want to, before I leave the scene or during the course of my assessment, potentially talk with some bystanders that may be able to tell me the sequence of events that happened. Or maybe I may come across, a close friend or family member that can give me a lot of the questions as far as the past medical history, medications, events that he might have been doing before this happened, and that could be a wealth of information. You have to accept the fact that sometimes you will not be able to get the answer to all of your questions. And so, if I can't get the answers to the questions, I can't get them, but that does not mean by a long shot that I'm done at all. So, one thing I wanted to talk about with this patient is the concept of reassessment, and reassessment should occur regardless of what patient we're taking care of. Just as Jason earlier, I gave him a dose of nitroglycerin, we got into the ambulance. After we got into the ambulance, I would want to repeat all of my assessments, determine whether or not he's still a candidate for the nitroglycerin, and then potentially continue that way. With this patient, what I'm trying to look for is just potentially the change for, or potential for him to start trending down. I want to make sure, he might be waking up, he might, his pulse might have disappeared. And so in order to do that, I need to basically repeat all of the assessments that I've done. And so first off, I want to repeat my primary assessment. I want to make sure that his airway is still patent. I want to make sure that he's still breathing. I may have my SpO2 on from my vital signs. I can monitor that, give me a wealth of information. I could check his breath sounds, as I should have done as a good EMT earlier. I would want to go ahead and just make sure that my patient still has a pulse. I can still palpate it in both areas. Okay? So I want to repeat that whole assessment. I also want to repeat my LOC. Okay? Hey, can you hear me? Hey, still no response. I want to say, hey, can you squeeze my fingers for me? Don't get a response. Maybe try the sternal rub on your classmates. Just do the pinch of the back of the hands. And again, if I still get no response, this patient is still unresponsive. If I have time, I may want to repeat my physical exam. I've got time to kill. It's him and I in the back of the ambulance. We don't have a whole lot to talk about, so that, at least the least I can do for him is to continue my assessment and maybe repeat and check all the areas of the body again. Some other things that I want to make sure, reassess his vital signs. This is a critical patient. It needs to be done every 5 minutes at least. About 15 minutes for your stable patients unless you need to administer medications. So I'm going to go ahead and recheck his vital signs at this time. And now what I want to do is to check any interventions. I don't know if you can hear it or not, but it sounds like my oxygen tank is running a little bit low. I'm in the ambulance. Maybe I want to transition them to the onboard oxygen. So very, very important that we monitor these things because a non-rebreather without oxygen is not doing your patient any favors at all. So want to make sure any intervention I've done, make sure straps are still good when we had this patient immobilized. Very, very important reassessment. And the last thing I want to do is to basically what we call reestablish patient priorities. I've dealt with the critical things. I've reassessed his airway. I know his breathing and his circulation are okay. Now I want to transition to some other measures, potentially some comfort measures. If I found that this patient had significant trauma, maybe now I would take the time to individually splint some extremity injuries. Maybe I would take the time to, cover up and dress maybe some small abrasions that weren't critically bleeding. And so that's going to be real patient dependent, but it just becomes part of what we do. Now that we've completed at least our first reassessment, and keep in mind, depending upon how far away we are from the hospital, we may do this multiple times. Again, while the patient's with us, they're our responsibility, and we need to continue, assessing and monitoring the patient's condition. But I do have my radio, and I want to make sure that I give a call to the hospital. This is a critical patient. He's unresponsive. At this time, we're not sure exactly why that might be, and so it's important to give them a heads up so that they can prepare for the potential situation. Now, this time I do not necessarily need a physician, but I do need to give them the information that I have found on this particular patient. So I call the hospital. This is a very, very quick kind of courtesy call, but this is Medic 1 to hospital.
Medic 1, this hospital, go ahead.
Okay. And hospital, this is EMT Craig aboard Medic 1, and we're en route to your facility with an approximately 10-minute ETA. We're coming in with an unresponsive 25-year-old male. Mechanism of injury or nature of illness is unknown at this time. We found the patient completely unresponsive. He has not responded to any of our interventions or assessments. Patient has a current GCS of 3, and the rest of his vital signs, this patient has a heart rate of 80, strong and regular. His blood pressure is 124/84. His respirations are 12 and unlabored. We did go ahead and put him on 15 liters non-rebreather. We were unable to obtain any history questions on this patient. We did get the patient immobilized to a long spine board and are en route to your facility. We have noticed no change throughout the course of transport. We have assessed this patient completely and are unable to determine the exact cause of his condition. As I said, we're about 10 minutes out, and unless you guys have any questions or orders, we'll see you in just a few minutes.
Copy. We'll give you a room upon arrival. We'll see you in 10 minutes.
Okay, copy that. Medic unit is out. And so again, we would continue through the rest of our assessments. I may start all over again and do it all over again, guys. Just because it's a reassessment does not mean that it only happens once. As I said, he's in my care. Need to make sure that I look for and try to identify potentially the cause of his condition. I may go ahead and check a blood glucose, some other things on this patient, but that gets into a little bit more specific disease process care, and that's something that your guys' instructors will talk you through. So that's all for our critical trauma or unresponsive patient assessment.